Hi, everyone. I'm Gabriella Maloney, and I want to thank you for the opportunity to be here today. We're going to be talking about managing widespread field cancerization. So we've all seen it, but how do we best manage it in the severe cases? Well, I've been practicing for about a year and a half, and as soon as I started, I inherited a couple of complicated cases I wanted to share with you. So we have a 73-year-old female with 15 plus treated SCCs. She grew up on the lake. She's had fulminant hepatitis on acetretin, severe reaction from PDT, and will not retry it. And she's very hesitant about fluorouracil due to the extent of her actinic damage. Another female in her 70s, she's had more than 20 SCCs treated. She had severe psoriasis since childhood and believes that she probably underwent 300 plus PUVA treatments over the course of many years. She's had severe hypertriglyceridemia on acetretin and methotrexate-induced pulmonary fibrosis. Also had a severe reaction to PDT and will not do it again. So what now? Let's review a couple of options. We all are familiar with fluorouracil. It's one of the most effective topical therapies. The cream can be less effective in hyperkeratotic lesions like in my patients. Intralesional might be a great option, but it can lead to multiple office visits, which in a world of high copays can be problematic and also lead to ulceration. Side effects are discouraging to some patients. Fluorouracil has been reported in combination with calcipotriol used BID for 4 days. It induces long-lasting T-cell mediated effects, which is very important in terms of long-term cancer prevention. It leads to better compliance because it's a shorter amount of time, but leads to more inflammation, which can take 10 to 14 days to subside. Chemo wraps, again, very old but a goodie. It's weekly fluorouracil treatments with zinc impregnated gauze for about 4 weeks. During that time, patients can't shower, which some might not like that. You can also use fluorouracil BID for 4 weeks with overnight occlusion with plastic wraps. I personally have a hard time convincing my patients to wrap themselves prior to going to sleep. But it has shown an AKA response of 60% after 9.5 sessions. So it's a huge time commitment, but it can help define tumor borders in case where there's no access to Mohs surgery. And again, limited to extremities. PDT, I have it in my practice. I use it all the time. It's FDA approved for non-hyperkeratotic AKs. There are many different protocols out there, which is nice. Very high regional response rates. You can use blue, red, or ambient light. Some have reported with lasers as well. But again, limited use on the trunk and insurance coverage can be an issue sometimes. Acetretin is a great option. I'm a huge fan, but very, very costly, hard to get covered. It has shown up to 60% decrease in those new squamous cell carcinomas, but long-term is required for long-term, for prolonged chemo prevention as cancer rebound has been shown after stopping. Nicotinamide, I recommend this like water. 500 milligrams BID has been shown to decrease squamous cells by 30% and number of AKs by 13% at 12 months. It requires no monitoring with very minimal side effects, and patients honestly love it because it's just an over-the-counter vitamin. The new kid on the block is tirbanibulin. It was literally just approved by the FDA for AKs on the face and scalp. It's an SRC kinase inhibitor that also inhibits tubulin polymerization. It'll be launched in the US early in the spring of 2021. And it's an ointment that's applied once a day for 4 days. Again, very easy to use and have shown a favorable side effect profile. There are a couple of other options we're all familiar with, but for the sake of time, we're going to just skip them today. So back to my patients. Again, I've exceeded all the other options that I mentioned, and my patients were exhausted from treatment fatigue, so I had to get creative. I had an idea, and I started looking at the endless options we have over the counter, and I encountered the often underestimated urea. So I wanted to add that to my repertoire and share it with the results with you. As we know, urea is antimicrobial and keratolytic at different concentrations. Urea is the end product of catabolism of animal proteins, which means it's not used as an energy source by pathogenic bacteria and does not promote pathogenic bacterial growth. It regulates epidermal structure and function by altering gene expression and enhances percutaneous absorption of various chemicals and pharmaceutical agents, which is really what I was most interested about. It promotes keratolysis by improving hydration of the stratus spinosum and has been used intralesionally to treat BCCs and SCCs with really good results. Also used as an adjunct for wound healing, which can be helpful in cases of severe widespread field cancerization. So why am I bringing this up? Well, after understanding all those properties, I started alternating BID use of urea and fluorouracil with great results at a very cost-effective manner. As you can see, 30% urea spot cream is about $7 for a 70-gram tube, and 5% urea lotion tends to run around $10 for a 500 ml bottle. You can do an optional third day of emollient only and really extend that drug holiday for your patient for comfort. Again, I do have to mention this is off-label. I found that the combination with urea, it helped absorption of fluorouracil by eliminating hyperkeratosis, and that has been studied before. Moisturizing leads to less pruritus and less potential for bacterial entry and infection. It's more tolerable as it gives patients a holiday from the chemotherapy regimen, and high compliance because it's less aggressive than the typical fluorouracil treatment. And again, very cost effective. Going back to my patients, you can see just 4 weeks after the treatment, you can see less hyperkeratosis and less erythema. 6 weeks, significantly less serous crusting and less hyperkeratosis. And again, 6 weeks after, significantly less erythema, less hyperkeratosis, and this patient reported significantly less pain. So again, patients who commented on less pain, less pruritus, less burning from the fluorouracil regimen, also reported improved quality of life. So I do think this is worth considering when everything else fails and your patients are just tired and not willing to go through anything else, and you just don't want to do 20 biopsies in one visit. And I hope this tip can help your practice like it helped my patients. Thank you very much.